Institute in Springfield, Missouri. And so I did have some experience there. I moved out to Colorado, started working for Kaiser Permanente, did a lot of stress testing, actually did some management in cardiovascular services. But for the past 8 years or so, I've been created a program. It's more individual one-on-one consultation versus a more group type atmosphere. I see just about any cardiology and vascular surgery patient in individual consultation, spend a lot of time with behavior change strategies, actually do physical testing, sometimes max stress testing, cardiopulmonary stress testing, other types of fitness testing, and then a lot of programming for each individual. I get a 90-minute time frame in which to work with these people one-on-one, and then most of our follow-up is individualistic. So I don't see them 2 or 3 times a week for so many weeks. A lot of it is I'll see them once, and I might not see them again at all. It may be all phone, email, follow-up, that type of thing. There are some individuals that I do see in follow-up from time to time. So I wanted to let you know kind of my perspective and how I work with these folks, because I think it's important to understand where I'm coming from. I'm not going to spend too much time reciting the latest in the literature. Some of the things that I have quoted and put in here as far as research on exercise and PAD is not the newest and latest, but I think it's very important. So I do go over a little bit of that, but I want to spend more time in kind of the guts and how I work with these people, and maybe it might help you with these individuals moving forward. Of course, understanding the disease, you should know the definitions of different things. An interesting, what I call the medical history minute here is the definition of claudication. Apparently, the Emperor Claudius had a bit of a limp, and that's pretty much where it came from originally. But I thought that was kind of an interesting little tidbit. But what's the prevalence? So let's get down to it. How many of these people are we seeing out there? PAD, it's about 12% of the general adult population. Once you start heading north of 70, they say about 20% of older adults over 70 have peripheral arterial disease. But just like coronary artery disease, just because you have some disease doesn't mean it's necessarily symptomatic. And of course, smokers and diabetics, as you get older, are going to have a much more significant prevalence of the disease. But it is usually underdiagnosed because many times the symptoms are not real typical, or they don't have necessarily any telltale symptoms at all. It can be a pretty vague and sneaky disease at times. And of course, there's different forms of claudication. It's not necessarily just from blockage of arterial flow. You could have more neuromuscular, maybe musculoskeletal components that kind of mimic very, very similar pain, and not very often, but I will tell you that I get maybe about between 15 to 20% of the patients that come from our vascular surgeons, where they actually have the origin of their pain has nothing to do with the blockage of arterial flow. It was just a coincidence. They just happened to have it diagnosed, but the pain came from other origins. So it can be tricky even for those that are well seasoned. But how is it that we do misinterpret? Of course, there's varying interpretations of pain. There's a little case study at the end where I misinterpreted symptoms of an individual, and we'll go over that towards the end. But different people use different terminology. I learned a long time ago when I was doing exercise stress testing to be careful of just using the word chest pain. Do you having any chest pain? Because you can have somebody say no, and then they say, oh yeah, but it feels really tight. So you have to be real careful on how you verbalize things, and I think that's where we get into trouble, especially in the primary care setting where a physician may be dealing with 5 or 6 different things that a patient presents in front of them, and so they'll use the word pain and then they'll skip right over what the actual symptom was. And then of course when you say, do you get it when you go out for a walk? Well, a walk can mean different things to different people. So people say, no, it happens only every once in a while. It's not consistent when I walk. Well, maybe they're talking about walking slowly in a grocery store versus going out some steps or going out for a walk for the sake of exercise. So there's different definitions that people throw in front of you. And then also what I see is, people say, well, it's gone. I don't have the discomfort anymore. And then we go over their history, and it seems that they have actually started to avoid, doing certain activities that require them to walk. They started walking a little slower, and maybe it was just enough where they dropped below that claudication pain threshold. And so a lot of times people will change their habits, which can make interviewing very important in understanding if that has happened, so you can better deal with it. As far as your real typical symptoms, and a lot of times people find this with walking. It can happen with other types of physical activity, but generally with walking, there's this real kind of a cramping. They may describe it as a tightness or pressure, or the good old-fashioned Charlie horse term. That's normally how you might hear about it. And it presents itself with walking, goes away with rest, comes back again with walking, goes away with rest, kind of like how we would analyze somebody with angina from their heart. Of course, the less obvious claudication symptoms, these are the ones that always are a little harder to deal with. There'll be kind of an ache, a burning, or even a fatigue. And a lot of times when I work with people, we start looking back historically. I have the time to go back and look at it, and a lot of it does start with just an unusual fatigue. People say my thighs were getting tired, my calves were getting tired. I'd just get a little more short of breath when I tried to walk further, and maybe the very start of their symptoms was just more of a fatigue. But as I've been comparing, with angina from the heart, it comes in different forms. And so when you're taking a history, it's really important to establish that pattern of symptoms, not necessarily exactly what it feels like to them. And as I've found out, it may be a tightness that they feel, but they take 2 or 3 sentences to describe the exact same term. So sometimes it takes a while to really elicit what they're feeling. And then also looking at what is really their most limiting feature. I mean, there are plenty of people that have other things going on, and especially if we're dealing with a population that's generally 70 plus, I mean, they're going to have arthritis. They're going to have maybe some neuromuscular, maybe they have a little sciatica going on. But maybe their limitation is more from their lungs than their heart. Maybe they've gone through cancer treatment and just the fatigue is the biggest issue, and it's really not the most limiting factor. So one of the things I'm going to stress as we go through with how to work with these people is to really make sure you're identifying what the most limiting feature is, and don't get too centered on, okay, when do you get that cramp in your left calf when you're walking and that type of thing, because sometimes you get a little too stuck on that and you forget to really work with what the most limiting factor is. So one of the things that I've noticed over the years in working with this population, since I get that privilege of being able to see these patients, knowing that there's not a lot of programs out there, is kind of what I call the decreased physical activity cycle. And it's real common sense. So when people have pain in their legs while walking, they slow down or even find ways to avoid it. Many will try some over-the-counter pain relievers, maybe get some massage. And then when it gets even worse, they may go see a doctor. And then depending on how well-versed the doctor is or how typical the symptoms are for PAD, they may go along that musculoskeletal route, or maybe they'll get some x-rays or MRIs of the back and look down that road. Give them some simple stretches to do. And then although they were supposed to follow up a week with their doctor, things get in the way, and maybe it's a few weeks or even months they go back. And the doctor may not do an ABI, maybe they do, maybe they refer to neurology. But sometimes it takes time to get the visit set up, so whoever they're going to see. And maybe they eventually get to a non-invasive vascular assessment, a NEVA, and then they go back to the doctor or vascular surgeon for the results. And then they go over the different options. But as you can see on what I have here, one of the things is, anywhere along here, did anyone suggest exercise? So when they started noticing their risk factors were out of line, maybe they started having a little more pain, maybe they did have an ABI, did they start suggesting exercise there? Then it goes a little further. Maybe they just kind of deal with it. It's not too problematic, but then it just starts to get worse. Was exercise suggested at that point? Then they started getting really limited. Was it done there? A lot of the times that I see people is all the way down here, and it could be months or even a couple of years. I mean, I've seen people 7 and 8 years after the fact, after it's been diagnosed, and physically they are just so deconditioned. They, have so many other things going on that it puts them in a really big hole, and it can be very difficult to work with these folks than if maybe up here when it was first diagnosed that we got really aggressive with it. Um, so it just really takes its toll on these people, and it's hard to get them to do exercise. Yep. Okay. I'm moving along here, so just hold on a second. There we go. Okay. So when we look at decreased activity, and then we put it in terms of survival rates. So you can see here, this graph was adapted in part from Gardner in 2008. They used the Johnson Space Center physical activity scale, where like 0 is avoiding all activities, 1 is really light, and their definition of active in this case was described at 2 or higher. And so 2 was being considered moderate physical activities done regularly for less than 1 hour per week, less than 60 minutes. I mean, our recommendations for the general population is 150 minutes a week. So you can see a marked difference in survival for those that are just engaged in even less than 60 minutes a week who have PAD. So even just getting these people started may have a profound effect a few years down the road. I'll apologize for the next few slides. They're a little busy. I don't want to spend too much time on the physiology of this. A lot of you are pretty well versed. But as you look at the mechanism of impairment and the benefits of exercise, as we start to turn the corner of this conversation and looking more towards prescribing exercise, these are, of course, the different things that you may see, improved collateral flow, improved mitochondrial, biogenesis, better extraction, decreased inflammation markers, just the improved walking mechanics of exercise. So these are all the things that could possibly contribute to what's going on. And I think my experience has been that, any particular individual may have any number of these things that help them. I can't really pinpoint any specific one that really contributes the most, since everyone's a little bit different in how they end up getting to me. When looking at how exercise measures up with other forms of traditional treatment, of course, we might get 120 to 400%, depending on which study you look at, improvement in the time to onset of pain and total exercise time. It's going to be safe. The morbidity and mortality rates with exercise is really low, and it has a direct impact on the risk and issues of functional decline. Some individuals end up getting angioplasty or stent, to their lower extremities. So in terms of symptom relief, it's a little bit more immediate. So a lot of people try to go that route initially. Of course, the amount of distance they can walk right afterwards sometimes isn't necessarily a lot different because of the physical decline that they have. So just their functional capacity period is down. So they may not, suddenly be going 1,000% more than they used to. It may be similar to those found with exercise. The safety of it is pretty safe procedures nowadays. But there is typically a higher restenosis rate than with, coronary stents and angioplasties. It is limited in its ability to be used because of the anatomy where they're trying to place the stent. But it also doesn't correct the underlying issues. There are probably, I'd say maybe about half of the people that I see with PAD have had a prior stent or angioplasty, and it ended up blocking back up, or they've just never really regained their functional ability afterwards, so they end up coming to see me for exercise training anyway. Looking at surgical, so your bypasses of the lower extremity, symptom relief is improved quickly, but the problem is the amount of recovery time from it. So they're not actually able to demonstrate very quickly because they're having a bit more time off their feet with an open procedure like that. So the initial improvements are maybe a little bit less than exercise. Of course, the safety is more of an issue. You have a 2 to 3% mortality, 5 to 10% morbidity, so things do go wrong during those surgeries. And once again, does it really correct the underlying issues? Are they really increasing the strength, the endurance, the extraction of oxygen at the muscles? I mean, it's not really happening if they just rely on the surgery alone. Medications are many times used in concert with either exercise or by themselves, I guess. The two that I see the most are cilostazol and pentoxiflin. Cilostazol, I think, has usually been found to be a little bit superior. But they can get maybe 100 to 150% improvement in maximal walking distance, which may be kind of a nice boost at the start. Down the road, though, it's not as typically as effective as used in either just exercise is used or if it's used in concert with exercise. So there's some studies that looked at using both, and they found some favorable results there. Of course, there's limited use of cilostazol, especially with people who have like heart failure. There's potential drug side effects, GI upset. But once again, if they're relying on the pills only, we're kind of missing the boat as far as helping correct some of the underlying issues they have. So when I see these individuals, the question is, do we really need to move forward with some type of form of exercise testing? So when you're talking about exercise testing, you talk about it on two different fronts. One is, of course, collecting data to help create your exercise prescription. So you're looking for the onset of symptoms, how long they can walk on a treadmill, and you may use that as objective information as a starting point, and then maybe 3 months, 6 months, a year down the road, that type of thing. And then some of the information that I really like is using like a pain trajectory, how quickly it sets in, but then how it kind of ramps up to maximal pain. Does it do it quickly? Does it do it slowly? That type of thing I find important. I'll go over that in a little bit. But the other question is screening. Do we really need to look at screening for ischemic heart disease with these individuals? Some people will say, well, they're so limited in how far they can go, we're really not going to get good information if you're doing an exercise test. Maybe you should look at pharmacological testing. Some folks will say if you're going to screen, maybe use a bike if it doesn't elicit the severe claudication symptoms, because they might be able to go more intense on a bike, and so you could watch them that way. Normally what I do, of course, is after I do a careful history of any potential cardiac symptoms, I normally go with whatever mode I'm going to be doing exercise for these individuals. So a good portion of them are walking. I go ahead and just monitor their heart with walking. And I will tell you, in the first 6 months or so when I started this program, it was about 50-50 that I sent people on to a cardiologist or on for interventions such as stents. My very first patient actually went on for bypass surgery. And that's the story I'll tell a little bit later. So I've had some success in heading some people off, but at least I know, even if it's pretty submaximal heart rate and blood pressure information I'm getting from doing a walking stress test with EKG alone, that for what I'm most likely asking them to do, that I've at least screened for that much, and then I'm just really careful to discuss with them about any potential onset of symptoms and things like that down the road. So in developing exercise prescription, what's considered best? So the top 4, we have walking. As everyone probably knows, most people think that walking is the only thing, but is it really the best? And in some instances, as I'll discuss with you, I'm not exactly sure that that is the case. So looking at walking first, the traditional modes, of course, are walking to pain tolerance. So each individual is a little bit different, but basically you get out and you walk until it hurts really bad, you stop and rest till it goes away, and you repeat that interval pattern over and over again. And the data has a bunch of information in there, and a study by Ratliff saw 100 to 250% increases in onset to pain and total distance achieved. But sometimes we have to put this in perspective. While this particular type of training has been tried and true and has been out there for a long time and is maybe the most suggested, one of the issues with it, let's put those gains in perspective for an individual, especially for someone who may be still a bit younger and is still in the workforce in their 50s and 60s. If somebody can only walk, half a block, and suddenly they're, up to a block and a half, we consider that a pretty good increase by percentage numbers. But when we look at it in realistic application, they're still feeling very limited and very frustrated. Somebody who's in 75, 80 years old, maybe they're going to be a little bit more satisfied with that type of progress. But once again, that's per individual. And it's kind of an unpleasant way to exercise. A lot of us that are prescribing this don't really know. We don't really feel it. So sometimes it's hard for us to sympathize or empathize correctly with these individuals. And some other groups have looked at pain-free or very low pain walking and exercise. So basically you try to have them walk just below either the threshold of pain onset but for a lot of people it may be the best place to start, and that's where that initial interview and really getting to know each individual is important, because if you get the sense that they're just really not willing to put up with the pain anymore, then this may be the best approach. It's slow, but it allows them to do some exercise to make some progress without having to deal with kind of the mental beating they get from having to put up with the pain every time they decide to exercise. Typically, I use kind of a sweet spot between those two with individuals. I very rarely suggest exercising to maximum pain tolerance. One of the reasons is I don't like the extra recovery time that usually comes along with that. I like to demonstrate to an individual a little bit better ratio of walking to resting. So I'll go somewhere in between. It's not pain-free, but it's not absolute maximal pain. So if you're using a 4 or 5 point scale, you go to either like a 3 or a 4 on the scale and stop them before maximal pain. Or sometimes I'll use thresholds like limping. Because I also don't want the individual to spend a lot of time limping while they're exercising, which starts leading to maybe some musculoskeletal discomforts that creep up over time. So maybe that limping threshold is where we stop. But I try to avoid using maximal pain. Looking at information as far as using a bike, if you look through the literature, most of the literature does suggest that treadmill or walking is still superior to the bike. Of course, that could be the specificity of it. You know, if you're trying to improve the ability to walk and you're trying to improve symptoms of claudication in the calf, then the bike may not be stimulating as directly as, of course, the walking would be. There is some information from, I believe it was Sanderson in 2006, where if the individual can cycle at high enough intensities that actually elicit the claudication pain, they've seen some improvements in walking. One of the things I look at is the adherence, and so the information from Turner in 2008 also touched on a little bit that you may get better adherence overall to an exercise plan if it's performed with less pain overall, and if in general we're also looking to improve someone's cardiovascular fitness, reduce the risk of cardiovascular events as a whole, then incorporating exercise into maybe a multi-mode approach using the bike may be a good place to work. So trying to make sure you don't get too focused on just one form of exercise with individuals can be helpful. Strengthening exercises, generally walking still wins. When you look at the research, I mean, there's not a tremendous amount. Overall, when you look at the amount of research that's been done with cardiovascular diseases, excluding peripheral artery disease, I mean, it's skewed quite a bit towards the others. So there's not necessarily a lot of consistency. The protocols are developed because they want to research a specific protocol of days per week and sets and weight and repetitions and percentage of max. And so that, to do research, the protocols do need to be, fairly rigid at times. So there's not necessarily a lot of individualization in the literature either. So you don't necessarily progress someone differently than another. You don't prescribe different exercises for somebody because it's in their best interest. So I think that, it's hard to take the information from the literature and say that strength training consistently provides good results, but there is some that does say that they see some improvements, and I stop to think it's not. I wonder if it's more due to improving just their overall weakness, and maybe it's not a direct effect on the disease itself or that type of thing. But if you specifically prescribe an exercise to improve lower extremity strength and endurance, that it's just taking that weakness part out of the equation, and then it allows you to start focusing more directly on the claudication symptoms themselves. So I think it's a very important part that needs to be addressed with each individual, because there are just, I will say, I think it's just as important because of just the individual health of the person, also helping with kind of their ability to mentally put up with the process and feeling like they're gaining control over part of their life. I think those types of issues are just as important as getting in interval walking, that type of thing. The first article I saw on this some time ago, I believe it was the Treat Jacobson study in 2009, before I started looking back further in the literature about arm ergometry, and noted that they started seeing improvements in time to onset of the symptoms. Not necessarily a lot of increased walking distance per se, because it's lacking the specificity, but it was altering the perception of the symptoms. And it kind of brings up the whole aspect of, is there a general cardiovascular conditioning effect that just helps in general with these symptoms? So maybe you don't have to focus all your time on stuff specifically for the legs if you can get some good conditioning in general through other means. And I really like the information from the study, and it allowed me to kind of open up my mind to other possibilities. Now, looking at no longer the modes, but what's the volume and intensity necessary to produce these favorable results? So when you look at Bulmer and Coombs back in 2004, they did a really nice synopsis, and the graphs in there were real nice and pretty, and they showed some good information. And it suggested, if we're looking at kind of the bottom end, so the numbers on here aren't necessarily ideal, but maybe more kind of those minimum thresholds that we need to look at to get these individuals to, and at least 3 days a week was found, and that kind of makes sense, especially if you have individuals who are extremely sedentary, then come in, that we know that if we affect any of the FIT principle, the frequency, intensity, and time that people are doing exercise, they're going to start conditioning a muscle. So 3 days a week makes sense. If I remember correctly, 4 to 5 days a week looked a little bit better than 3. But when you got to 6 to 7, it with the information that they gathered, it didn't appear to give a much greater return on the investment of exercise than week with this particular population. Once again, I do things very individualistic. I don't stick with just their suggestions, but it was interesting to see. As far as minutes per session, 30 to 60 minutes was found, and that's kind of a no-brainer. As far as weeks of training, so a lot of this was limited to the research studies and how long they had them going. So we don't really know, the actual optimal amount of weeks somebody needs to be training to get the absolute best results. But 12 to 24 weeks compared to maybe 36 to 48 appeared to be kind of the threshold you want to look for. You don't want to do less than that. You could look at the total volume of training and how many minutes an individual may be actually exercising, and they suggested 2,000 to 3,000. But as far as work to rest ratios and intensity, that's where you start getting stumped, because everyone was much different. And when you don't have a lot of people repeating the same type of regimens, the same amount of weeks, the same modes, the same work to rest ratios, the same intensities, it's hard to really gather what is ideal. As far as having to measure progress, this is where I think we're going to find more value in this talk today, is the upcoming slides that I'll be presenting to you here. As far as measuring how well people are doing, there's of course objective measures, subjective measures, and specificity. So when doing exercise testing, of course, you want to see what they're capable of doing. So the total amount of time they're walking. And you also want to know when they start having the onset of symptoms. The other thing that I really do suggest people look into is also some other subjective measures, how short of breath somebody is, how uncomfortable they are overall, that pain trajectory that I'll go over in a little bit, I think is important. And then also the specificity. So if you're using an exercise bike as your screening method, but you're trying to measure how well they're walking, then your measurements aren't going to necessarily be as valuable. So I'd make sure that you try to tie your exercise testing into the main mode of what they're going to be doing. Pain trajectories. So getting back into that, there's also some information from Treat Jacobson in 2011. Our typical methods of measuring progress, of course, is how long it takes for the onset of pain. Using a particular protocol, either on a bike or treadmill or whatever you're using to measure. And then maximal exercise tolerance. And so you're looking for, the onset of pain to start taking longer, and of course their maximal tolerance, being able to do more. The trajectory looks at the progression of the severity. So, and I use this to identify more subtle changes with an individual. And explaining these changes in trajectories may help with demonstrating progress to the patients, which is something else that I think is valuable, especially when you don't have a lot of visits with these individuals. So basically what you're looking at is how it progresses over time. So on this, I use a 0 to 5 point scale for myself, but I've noticed 3 kind of general categories that these people fall into. Is then after they hit the onset of pain, you see kind of a linear rise over the course of every 30 to 60 seconds, and until they get to the point where they have to stop. There's the slow but sure. It kind of sets in, but it just doesn't move a lot initially until you really hit that threshold and that intensity where it just kind of shoots right up. And in some individuals, you'll see it come on pretty early and be fairly uncomfortable, but then they just kind of ride it out for quite some time before they get to the point where they have to stop. And seeing somebody go from maybe a fast rise there on the right hand side of the screen to maybe a slow but sure, ultimately maybe they're still getting enough pain that it stops them, but seeing the progress and how it starts to set in can be a valuable tool when working with these individuals. And really careful documentation of their initial and subsequent descriptions is important. So this is why, I realize that when I have 90 minutes to work with an individual, that's not necessarily the norm. If you have kind of a group exercise setting, maybe a more traditional outpatient rehab center, you'll have multiple times maybe, talk with patients, so you could kind of accumulate information over time. But I think it's really important on any initial interview or interest into a program, or that you get a really good description. So when people just say, oh, it just hurts, I don't let them stop with that. I need them to describe to me, what does it actually feel like? Does it feel tight? Does it feel pressure? Does it feel like it's going to explode from the inside? Is it an ache or burning? What is the actual sensation? Because sometimes those change over time too. And so the more information you get up front, the more you can see if things are actually changing for the better. And then of course the time to first onset. So a lot of people talk in terms of blocks, how many blocks they can walk. Then, of course, there's a lot of different sizes of blocks. Where I am here in the middle of Denver, when people live in this area and they come to me, they say, I can walk about half a block, and then I have to ask, well, is it the north-south or is it the east-west direction? Because the north-south is about twice as long as the east-west. And so understanding that is helpful. And then if they have like a real typical route that they walk, they have they say maybe they do a 3-block route, or they walk a mile, or whatever it may be, and noting the total amount of time it takes them is important, and how many stops they take during that is important, and then how it progresses, that trajectory thing I was talking about. And then also noting if there's some differences between activities of daily living versus actual exercise. And that's an important factor that I'll discuss later as well. And then, of course, the type of programs that you have available to you. The one thing I'll say is that there are, outside of those who are actually conducting research on exercise, there's very few outpatient programs. We have a great bunch of individuals at the University of Colorado here in Denver, but I believe that outside of research, that their rehab center doesn't really see a lot of people with PAD unless they have heart failure or CAD indications to go. So I think I may have one of the only ones in the state, and and I'm not sure how many there are actually in the region. So a lot of times individuals are end up working with people more remotely in this case. But when you look at the research, the evidence that is out there, the thing that really comes out each time you read about, what's superior, a home versus a clinic type program, it's how do you get them to adhere to it one way or another. It's important. But the more support, the better, especially if you are running more of a home-based program. You're having to give advice over phone, email, letter, that type of thing. These individuals also need probably a nice comprehensive support as well. So making sure that they're getting dietary support, they're getting emotional support, they're getting the exercise support, they're getting all the different things that they need, because the more you just give them information to exercise and send them on their own, the more likely they are to fail. So the more comprehensive, the better, of course. As far as troubleshooting particular individuals, one of the most common complaints I hear is, I'm not getting better. My leg still hurts when I exercise. And so I will call an individual and I hear him make this statement, and it can be very, very frustrating. So what I want to know is I get the details. So you'll hear me say this time and time again that I'm looking for any details that they can provide. Ask about how far they're going, how long it takes them, how often they're stopping, pain trajectories, those types of things. Because one of the things that I notice is that as people start making some improvement, they start going naturally a little bit faster. And so they still say, it still hurts just as much as it did before. But when you ask how long it takes them, they say, well, my route used to take me 30 minutes, now it takes 25. So it's like, then I spend time explaining to them how that is progress. I used to stop 4 times, now I stop 3. It's like, well, yeah, you're starting to make progress. You're taking less stops, you're going a bit faster. Maybe it hurts less at the beginning. So those are important things to do, because a lot of times they will focus all their attention on just the fact that they still have pain. If I do see that they are starting to, cover their course faster or things like that, sometimes I'll ask them to set what I call a benchmark day to better assess their progress. So maybe once a week I say, I give you permission not to do the intervals, and I just want you to go nice and slow at a normal, steady pace, and just allow yourself to go maybe at a speed you used to, and use that to help assess whether you're making progress. Because if you keep going faster, you keep pushing harder, of course you're still going to feel pain. So I think that's a very important thing to note. Then there's those that say, I've been doing this for 6 to 8 weeks and I just can't stand the pain anymore. And this is a hard one to deal with, especially if you don't see them very often, because you don't have that chance to interact with them to really see exactly what they're doing. So there's times that if the person was going 5, 6, 7 days a week, I started installing a strategic day off, like maybe 2 days on, 1 day off, and allow them just to get away from it mentally. Exchange a walking day with a less painful mode. Maybe they like to swim, maybe they like to go in the pool. Just allow them to go do some exercise, something that may not be specifically trying to help with the claudication they have from their PAD, but it allows them to take a mental break. And then there are some individuals, this is a pretty rare for me, as I said, I usually stay away from super intense intervals, but I say, you know what, you've been stuck at, 2.5 laps around that track at the fitness club you go to. So what I want you to do is to take 3 weeks and just do 1 lap as fast as you can. Rest, do another lap as fast as you can. In other words, just mix it up like you would with any normal healthy individual, or someone that's trying to improve their athletic performance, and you do maybe some shorter, more intense intervals. I've used it with success in some cases. Like I said, I try to stay away from that, but in general, as long as they're not having any worrisome cardiovascular symptoms, things like that, I go ahead and give it a try from time to time, and it has worked. It hurts too much to walk more than 1 to 2 minutes. They may be really severely deconditioned, and with people who really just can't go very far at all, my shortest test of all time was 38 seconds. I've had a few that have lasted a minute. I've had a few that lasted a minute and a half. And if they're severely deconditioned, that's that's part of their mix of why they're limited. And then sometimes I start with just about any type of exercise, just to get them moving, just to get them going, and then over time start switching them over to more specifically what they need to do for their claudication. Maybe you start out with low volume, low intensity, some lower body strengthening exercises, non-weight bearing cardiovascular, and then just add some weight bearing stuff in very slowly, or go with alternatives, less painful modes, just to get them in the habit of exercising. Because at least if we can create a good habit, they change their behavior, they start to exercise on a regular basis. Changing the mode of exercise is a lot easier than just trying to get them to do it in the first place. A couple of the case studies that I have on here. This was my miracle child here. We'll call him Al. He was 82 years old, and he had borderline bilateral SFA stenosis. His ABIs are actually 0.82 and 0.85, so they weren't real severe to begin with. He had no significant low back issues, maybe some bilateral hip and knee arthritic changes. Been sedentary for a couple of years. His legs got really stiff when he walked, and similar symptoms actually if he sat for too long or stayed in one position for too long. He did used to be a former runner. I evaluated him. I did a treadmill test. He went 15 minutes on a pretty typical PAD type protocol. It was 2 miles an hour and increased 3.5% every 3 minutes. Fatigue was the primary limitation. It wasn't like a pain or the stiffness that really stopped him. It was just fatigue. So my thought process was that I think that his PAD was just coincidental, and his other issues were actually the most limiting. So we went to a 5-day-a-week, 20 minutes of a constant speed walking with light upper body strength band exercises, a few body weight chair squats and calf raises. So real simple, not real high volume either, just 20 minutes. And I followed up with him in 2 weeks, and the pain and stiffness in his legs actually resolved. His thigh discomfort, he had a little bit after he did his chair squats, but nothing that was too bad, and decreased symptoms of stiffness when he would sit or stand for long periods of time. So this really was a demonstration of one of those situations where they came in and it was documented as having PAD, but it really wasn't the thing that was limiting him. And of course he thought I was wonderful, but I had to admit to him, I said that, I don't think that was the issue. It was really the other stuff. I mean, and then, I had a lot of education on more typical symptoms that he might have if PAD did start becoming a problem for him. But he was very grateful, and it's always nice to have an easier person to work with. This was actually my first referral from vascular surgery. If you listened to me earlier, you already know the outcome, but he was a 61-year-old male. He did have a left SFA and bilateral iliac disease. The iliac disease is questionable, significant, but he was still smoking. He denied any chest pain, but was also pretty short of breath with exertion. But his main complaint that he was focused on personally was his left leg tightness when he was walking. And he suggests that he gets significant pain in less than a block of walking and stops by the end of a block to rest. So I used a pretty typical PAD protocol, and within 30 seconds, the guy was reaching up and actually doing that real classic clutching of the chest. And on the EKG, I saw ST elevations. So we stopped at that 38 seconds and transported him to the hospital. He ended up having bypass the next day. So what was it that was missed? Well, why didn't I notice that? And one was his definition of chest pain. And he admitted to me later that he actually stopped to rest 3 times from the parking garage to the exam room due to shortness of breath and chest discomfort. So he actually wasn't having pain, but it was just this discomfort they had in his chest, so he didn't admit to it. So I didn't define what was most limiting to him, only that he got leg pain with walking. Didn't ask his version of chest pain or shortness of breath, and I didn't check to see if that was actually the most limiting thing. I only discussed what he was focused on and didn't do a complete exam. So I chalked that one up to experience. Fortunately, the outcome was for the better. As far as how to succeed with these individuals, consider the amount of contact time that you're going to have. What does your follow-up look like? Are you going to have visits with them, phone calls, emails, letters? How do you follow up with these people? And then how long do you follow up with them? I don't have any particular expiration date on when I stop seeing people. It's all very much a gut decision that I use, but I still have individuals that will occasionally drop an email or phone call 5 years down the road that just have questions. So fortunately in my situation, I'm able to do that. Establishing trust is one of the things that I think is the absolute most important. especially if you're going to have limited visits with these people. So I make sure I know what's going on with them before they arrive. Now, we do have a really nice comprehensive electronic medical record here, and it allows me to do that, but I want to actually act like I'm interested and I know what's going on with their health. So I want to know some of the other things that may be going on with them so I can really help steer them in the right direction. And then some of this you would think is common sense, but I don't see this every time if I go visit a colleague in another setting, I don't always see this going on, but I look them in the eye, shake their hand, ask them how they're doing. And then the first set of questions I work, especially with new people, is what are the questions, concerns that they want to make sure get answered? Because they may be thinking in their mind that they have a completely different agenda than what you have going on. So it's important that you get their questions answered. Another challenging thing, especially with electronic medical records, is talking to them and not the computer. I know this is easier said than done. When you're in a faster pace, maybe you have less time to work with these individuals and you need to get stuff down in their medical record. It's really tempting to be typing on the computer while you're trying to talk with them. Maybe you set up your interview area where it makes it a little bit easier, but I find backing myself off of the keyboard, using a pen and paper and looking at them and talk to them really helps kind of gain their trust. They trust that you're there for them. Make sure you do active listening, communication skills. But at the end of the appointment, do not assume that they've heard everything. If any of you have ever worked inpatient in the hospital, you know how little they actually absorb in that setting. Well, in the clinic setting, they probably absorb more, but it's still not 100%. So even if they do take notes, and sometimes I encourage them to do so if they want to put things in their own words, but I think they need to have a plan in writing from you, diagrams of exercises when possible, and what the follow-up will look like. Don't assume that they know exactly what you're talking about, even when they shake their head at you, because they may not. And then what type of progress are they going to consider success? Is it going faster and further overall, regardless if they have pain? I have some individuals say, I don't care if I have pain, I just want to be able to do more. Is it going further before they start to feel the pain? Is it just lowering the amount of pain overall, or do they actually expect you to eliminate the pain? One of the things I never do is guarantee that the pain is completely gone, of course, with these people. But sometimes that's their expectation, so make sure you understand what those may be. And then also remembering that a person's emotions can contribute greatly to their pain. Regardless of the physiology of the individual, the psychology ends up being their reality. And you have to gain an understanding of all the possible factors that may be leading to their pain. And you may not be able to address all of them, but you're probably going to have to deal with multiple contributors. Just remember that personal and financial stressors also may worsen the situation, as much as lack of blood flow, arthritis, neuropathies, and any other musculoskeletal or neuromuscular issue. All these things play a big role. The mind is very powerful, as many of us know, because in our industry, I think a lot of us end up saying, we end up being psychologists as well as physiologists. So in the end, we just need to make sure we get these individuals active, any way you can possibly do it. So now I think we have a few minutes for questions, so I would entertain any questions that Elizabeth may have at this point.
Okay, the first question I see is evidence of lower leg colorization any more common in this condition in comparison to the heart colorization?
Okay. I don't know the actual stats on that. So the one thing that I make sure I go over with individuals that don't have any history of heart disease is that it can be anywhere. So, they may have peripheral disease in their carotids, they could have subclavian things, they could have stuff in the heart. So that's why I think it's really important that we do a good full interview with these people. But as far as giving you, percentage of individuals that have PAD who have CAD, couldn't tell you. I'll tell you that if they probably did an angiogram on these individuals, that they would pick up some amount of plaque in the arteries. It may not be, obstructive, but giving you percentages would be hard.
All right, the next question is, have you found that a heart rate increases due to pain encountered during exercise rather than the physical effort?
Good question. That I think we do know that pain has effects on heart rate and blood pressures in general. I think during exercise itself, once you start engaging in it, I don't know how much more it actually goes up. One of the things that's always confounding with these individuals is a lot of them have been started on beta blockers as either they already have known heart disease, or the physicians have been proactive and have started on like aspirin and a statin and a beta blocker. So um, uh, they're all over the place as far as medical regimens when they come in to see me. So I haven't seen necessarily a huge impact from the pain, just making the heart rate go up considerably higher. So if you looked at like a trajectory on a scale of their heart rates, I don't see it at the higher rates where it gets really higher, but I'm sure it may have some effect.
All right. Compared to the PAD test termination level, what level, speed, grade do you start training?
Okay, so yeah, one of the questions is, so there's, I think if you look like, in ACSM, guidelines and things like that, if you're using like a 2 or 3 minute stage protocol, the stage at which the pain set in. So if it set in at 2 miles an hour and 3.5%, let's say it started at that level, some people will use that as the starting gauge and then work from there. And then, once they're able to get to a certain amount of minutes that they're able to tolerate that, then they'll, bump up the intensity. Um, I don't necessarily follow that logic, and some of the protocols I used are actually ramped protocols instead of stage protocols. So uh, I try to use a more subjective approach as far as the pain, and then also looking at the interview that I did and understanding how much pain they're willing to put up with, because you could do one where somebody's at 2 miles an hour and 3.5%, but they only go for 3 minutes. I back it off to 2 miles an hour flat, and suddenly they're going 8, 9, 10 minutes. Maybe they have minimal pain, but sometimes that's a better approach with some individuals because it allows them to do more. It feels like they're actually accomplishing a bit more. And I have more success working with individuals that can do a bit more at the start than those who only can go 2 and 3 minutes at a time, especially when I'm not able to be there with them. Now, if I worked in a more traditional setting and I saw them 2 or 3 days a week, I might change my tune a little bit, but that's because I'd be there personally to direct them. So I don't have, a specific formula that I use. It's very individualistic.
Here's another question. What are some screening tools to diagnose PAD?
Well, one of the things that it's amazingly sensitive is that ankle brachial index. So if you look it up, you're basically taking a blood pressure on the arm, and then you're taking pressures at a couple of points down on the foot. And so you have your blood pressure cuff just above the ankle on the foot. And I use a little simple Doppler device to pick up the pressures using a stethoscope. Is not a very good practice in that case, because sometimes it's hard to find the pulses, especially if they have significant PAD in the lower extremities. So using a small Doppler, and I have actually one that fits into my pocket, so thanks to my manager for that one, Stephanie. And it works really well, and it's amazingly sensitive. And so what you're looking for is the ratio between the upper and lower parts of the body. And so if your pressure that you detect, and you take the top number, so the systolic pressure at the top, let's say it's 140. So ideally, the 2 locations that you do down the ankle would also be right around 140. So around a 1. Once that starts heading below 0.9, so in other words, the pressures down below are getting considerably lower than the one up top, that's where it starts to become significant. And you want to calculate both sides, of course, so you're being thorough. Later on, if you're just looking for changes, you can be a little bit more selective, but doing the right and left side of the body is a really good way to start. And especially if somebody has pretty vague symptoms and your staff is versed in using this stuff, you have them lie down for, I think, 4 or 5 minutes, and just relax, talking to them. You find your little places where you're going to do the marks, take your pressures, and it's an amazing place to start. I mean, you can get more involved with what's called a NEVA where you're adding that, and they do multiple levels at the thigh and the calf and the ankle, and then they use an ultrasound to actually watch the flow where it is. Would be kind of the next step to confirm where it is and how extensive it is. But that first, just kind of bedside ABI, a great way to start.
Here's another good question. With a rest work interval, would you promote a more active rest or a passive rest?
So some of the thinking is if you do an active rest and you don't actually eliminate all their pain, then there's still a little bit ischemic. And so you may get a quicker onset of maximal pain tolerance on a subsequent interval. So there are some individuals, as they progress, though, I start putting a more active rest in there. But I think initially I do a complete rest as much as possible. And as far as, like ratios, I love to see them get to at least a 2-to-1 walking to resting initially, just so they feel like they're doing a little bit more. So I try to adjust my prescription accordingly. It doesn't always work, and some people are kind of in reverse of that, but that's what I kind of strive for to start with, and then use a complete rest. And then if they are actually able to just slow down and they get total pain relief, and when they start back up, if they're doing an active rest and it doesn't shorten the subsequent interval too much, then I would start moving them in that direction. So that was a great question.
All right, next question. When creating an exercise program, do you recommend using the pain scale or as guide or RPE for intensity?
I like pain scale better, personally. You could, I think if you're testing them and you're kind of doing a combination of the two, and you're getting an idea of pain and RPE, and you can make some assumptions about if they have a certain RPE, then they probably have a certain amount of pain. So if you're able to kind of correlate them together, that doesn't always work real well. But if you feel that that could be reliable, then I think an RPE would work in general. But I generally use pain scales. Now, if they start becoming either the pain is really very mild at best and it's really not a limiting factor, then I think switching to an RPE would be very appropriate. But as long as pain is their most limiting factor, that's what I would use anyway.
All right, we have time for one more question. When walking to pain, resting, and repeat, do you have your patients stop or slow down, then repeat?
Could you say that again? I'm sorry.
When walking to pain, resting, and repeat, do you have your patients stop or slow down, then repeat?
Okay, that's similar to the active recovery question. So once again, when I have them repeat, I usually will have them stop completely. Now, the one exception to that rule, of course, would be the person's environment that they're in. So if there's not good places to rest, or they don't live in the greatest neighborhood, so they don't feel like standing around, they want to keep moving, then maybe it's in their best interest to do that. But if at all possible, I will want them to rest. I want to try to resolve the ischemic condition that's kind of going on in there before they start exercising again if I can. They may still be slightly ischemic in the leg, but I just think it gives me better ratios in the end when I'm working towards that.
Okay, and that's all we have for questions. If you guys have any other questions, feel free to email SEPA. And thank you, Mark.
Absolutely.